Our next speaker actually is very well known in this world. Dr. Alan Bell is a family physician in Toronto, passionate about education for the last 2 or 3 decades. He's also assistant professor at the University of Toronto. He is the vice president of Thrombosis Canada and has been very instrumental in a lot of our initiatives. In addition, he's very involved with guidelines. He's been very involved in antiplatelet guidelines. He's been involved in these guidelines that you're seeing here with aspirin and primary prevention. He's been involved with hypertension guidelines. So passionate about education, formulates guidelines, speaks internationally. So we're very lucky to have him, and I feel very fortunate to work with Alan. So Alan, welcome, and go ahead.
Well, thank you very much, Jeff. It's always a pleasure to work with you as well. So right back at you. It's my task today to speak about ASA and primary prevention, which recently has become a rather exciting, hot topic. Now, I'm going to advance these things. Well, it says I'm still viewing the screen, so I think you have to pass over control to me, somebody, please.
Alan, you have to request permission at the top.
Oh. There is no ask permission thing.
Alan, look where it says view options and click on that at the top.
Ah. Excellent. Thanks, guys. All right. Okay. Aspirin and primary prevention. These are my disclosures. I'm not going to walk through them all. I'll give you a moment to view them. So the learning objectives today are to take a look at what is the evidence for use of ASA in primary prevention. I also want to touch a little bit on a very different topic, and that is the use of ASA in secondary prevention. Secondly, I want to hope that after this session you'll be better able to interpret and apply recommendations for the use of aspirin in primary prevention. And I also want to talk about, where we still don't really have answers on this topic. So first of all, a lot of this stuff gets sloshed around. A recent poll estimated that there are over 5 million individuals who have been recommended to take aspirin by a healthcare professional for cardiovascular reasons. About 3 million of those are actually doing it. And there's another 2.5 million Canadians out there who are taking aspirin on their own without medical advice. And if you add all those numbers up, you get about 5.35 million Canadians, and considering our population is about 30 million, that's 1 in 6 Canadians out there who is taking ASA for reasons other than curing their headache, and that's about twice as high as the number of patients in Canada with coronary artery disease. Now you have to add in the number of patients with stroke and with PAD who are not using it as primary prevention, but that still leaves a big whack of people out there using ASA for primary prevention. Now, although the topic is pretty hot right now because of the release of the stroke best practices guidelines, as well as the 3 big trials that were all released in 2018, I want to point out that this is not a new topic at all. And in fact, this guideline from the Canadian Cardiovascular Society, with some a great deal of input actually from Thrombosis Canada, made a clear statement on this based on existing evidence almost a decade ago. And that was that for men and women without evidence of manifest vascular disease, the use of ASA at any dose is not recommended for routine use to prevent ischemic vascular events. And we gave that a level A recommendation, 2011. And we based that on a very thorough literature search at the time, but a lot of it was very nicely put together by the Antithrombotic Trialist collaboration. And that work, which looked at the major studies that were available back in 2009, showed us this, which was kind of interesting. What you see in the red bars are the relative risk of having a vascular event taking aspirin for primary prevention and in blue for secondary prevention. And I think what is really striking about this graph is that the relative risk reduction of using ASA in patients who have had vascular events and patients who have not had vascular events is very similar. It's very close. However, the truth is in the absolute risk reductions, and that's a drum that I've been beating for a long time too, to get people to look at what are the absolute benefits of using therapies. And in the case of primary versus secondary prevention, it's night and day. As you can see, to prevent major coronary events, non-fatal MI, major vascular events, any vascular event, the numbers needed to treat in primary prevention are huge. 2,000 to prevent a non-fatal MI compared to only 150 at the time to prevent it in secondary prevention. And that is the sort of data that drove us to the conclusion that if you're going to be using a treatment initiative and you have to treat 2,000 patients to prevent a single event over a number of years, then you have to really question that event, particularly if it is associated with significant side effects. And in the case of aspirin, the terminology baby aspirin has led us to believe that this is a super safe therapy, but not as safe as you may believe. In fact, there are small relative and even small absolute benefits from the data that we had back in 2009 from the antithrombotic trialists. But the risk that is associated with it, and that is bleeding, even bleeding into one's head and causing hemorrhagic stroke, are also significantly increased. So there is a price to pay. So, for whatever benefit we get in preventing ischemic vascular events, we're losing in terms of hemorrhagic events. So the reason that we're all talking about this now is in 2018, three very large, ambitious trials were released: the Esprit trial, the ARRIVE trial, and the ASCEND trial. And based on the results of these trials, as well as on previous evidence, the Canadian Stroke Best Practice Recommendations decided to write a guideline which was published in the Canadian Medical Association Journal around the use of ASA in primary prevention. So let's take a look at what it is that was so exciting about these three trials that really brought this to light. And the first one I want to talk about is ARRIVE. It was published in the Lancet in 2018, and it was a randomized, double-blind, placebo-controlled trial that included men who were over the age of 55 with a couple of risk factors, anywhere from 2 to 4 risk factors, women over the age of 60 with at least 3 risk factors. In addition, obviously, they had to be primary prevention patients, meaning no history of vascular events or procedures. They couldn't be patients who, for example, underwent PCI for stable coronary disease. So these are patients who, as far as we could tell, had no evidence of vascular disease. I want to point out, however, that patients with diabetes were excluded, patients with ulcers or a history of GI bleeding were excluded, of course, any previous vascular event, the use of any antithrombotic agents, as well as frequent use of non-steroidal anti-inflammatory drugs. All of these were put in as safety considerations. So, as I say, double-blind, randomized, 100 milligrams of enteric-coated aspirin versus placebo, primary outcome being 5-point MACE, CV death, MI, unstable angina, stroke, or TIA. 12,500 patients were randomized for 5 years with a mean age of 64. And what did they find? They found that the aspirin had an effect, all right. It increased bleeding, but it did not provide any reduction in the primary outcome or any component of that outcome. It doubled the risk of GI bleeding on the other side of the coin. But, I will point out that the rate of GI bleeding went from 0.46 to 0.97, so about a 0.5% absolute risk increase of gastrointestinal bleeding, meaning the number needed to harm was around 200. But what's the point? Even that may seem relatively small, why take the risk if you're not providing any benefit to this population who you may previously have considered treating with aspirin, or who are out there doing it on their own because their uncle, who knows so much about medicine and used to be a nurse, told them to do it. So here are the Kaplan-Meier's, and you'll see that for all of the outcomes listed, MI, stroke, CV death, etc., all of them pretty much follow the same line, the exception being gastrointestinal bleeding, which is highly significantly increased, roughly doubling the rates. One might say, well, you know, maybe what we should do is take a closer look at these patients, and the ones who we consider to be at very high risk, maybe those are the ones that we should be giving aspirin. And in fact, the authors of this trial looked carefully at that, and they gave the cardiovascular risk by quartiles. And what we see is this side favors aspirin, this side favors placebo. And for, interestingly, and I'm not sure what the relevance of this is, but the group, in fact, in this particular study that favored the use of aspirin were the ones who were actually at the lowest cardiovascular risk. So, you know, this would argue strongly against risk stratifying your patients and giving aspirin for primary prevention to high-risk patients only, because that would not seem to make sense either. The next study I want to review is called Esprit. Esprit is a similar design to the previous study. However, this one focused on the geriatric population. Patients were included if you were Caucasian and at least 70 years of age, or if you were Black or Hispanic and at least 65. You were excluded if you weren't primary prevention, so any history of vascular events. You were also excluded for dementia or chronic disability. It was again double-blind, 100 milligrams of enteric-coated aspirin versus placebo, and the primary outcome was a composite of both bleeding and cardiovascular events, so major hemorrhage and cardiovascular disease, which had a fairly wide definition and also included hospitalization for heart failure, as well as the usual fatal, non-fatal MI or stroke. Over 19,000 patients, 74 years of age, over 4.5 years of follow-up, once again in this population who we are very tempted to give low-dose aspirin to prevent vascular events. No benefit was seen with aspirin, but once again, we saw a statistically significant 38%, almost 40% increase in the risk of major hemorrhage, with a very similar absolute risk increase that we saw in the Aspire trial. And here are the CV and bleeding outcomes. You see the CV rates stay, you know, pretty much superimposed upon one another, with a 95 a hazard ratio of 0.95, and on the other side of the coin, we see that the curves for bleeding separate very early, are clinically significant, with almost a 40% increase in the risk of major hemorrhage. Now, the paper that I just showed you was actually part of 2 companion papers that were both published at the same time in the New England Journal. The second paper focused specifically on mortality and cancer associated with ASA. There had been a lot of speculation in the past that ASA was perhaps protective in terms of cancers, particularly gastrointestinal cancers, and in fact, that was not seen. The rate of cancer was actually higher in the aspirin group. I'm not suggesting that aspirin causes cancer, but that was clearly an observed result, as was the overall mortality risk, increased by about 14% in individuals who were taking ASA. And there's, once again, I'll show you quickly the Kaplan-Meier curves for cancer. And you know, it's a little bit disturbing. We didn't see any separation until almost 4 years, at which time, you know, there was a pretty sharp separation that occurred in this cancer group. And, you know, it's troubling that we see sort of these crocodile jaws with continued expansion going out to 5 and 6 years and perhaps beyond. So for those of you who are thinking, well, maybe it doesn't do anything for cardiovascular disease, I'll use it for cancer prevention, don't think so. Finally, the ASCEND trial did a similar study looking particularly at patients with diabetes. You'll remember the first trial I told you about, Aspire, did not include patients with diabetes. This one included any patient who was 40 years of age or over with type 1 or type 2 diabetes, once again excluded with any history of cardiovascular disease or any indication for antithrombotic therapy. 100 milligrams of ASA, enteric-coated or placebo. Here is the primary endpoint, 3-point MACE, MI, stroke, or vascular disease. But that did not include hemorrhagic stroke on the vascular side. Primary safety outcome was the first occurrence of any major bleeding. 15,000 diabetic patients, mean age of 63 years, followed for 7.5 years. As I mentioned, these are very significant trials. And in fact, in this trial, we did see a benefit for aspirin in terms of reducing the primary outcome, about a 12% relative risk reduction, about a 1% absolute risk reduction, indicating a number needed to treat to prevent a vascular event of about 100, a number that we often will consider a reasonable number to initiate a therapy, a number needed to treat of 100 or less. But the primary safety outcome, you will notice also, this time increased by almost 30% for hemorrhage, with again about a 1% increased risk. So a number needed to harm also around 100. So for every vascular event that we're preventing in these patients, we are causing hemorrhagic event. And again, I will show you the Kaplan-Meiers showing that they seem to separate fairly early, but at around 3 years or so, they run very parallel to each other. And if we take a look at sort of this landmark analysis, looked at the occurrences in the first 3 years compared to subsequent years, what we observe is that all the benefits seem to be up front, and we don't see any ongoing benefit that was seen in the subsequent years. Food for thought, consideration. We also see the individual bleeding endpoints. They were all pretty much increased, other than the pre-specified site-threatening bleeding. But we certainly do see an overall increase that was driven mainly by gastrointestinal and other major bleeding, for an overall 30% increased risk in major hemorrhagic events. So what about risk stratifying the diabetics? Maybe what we can do here, like was suggested earlier, is to give aspirin only to the diabetics who are at high risk. Well, the authors took a look at that and broke their population down by their 5-year cardiovascular risk. So those are at low risk, less than 5%. Those are at intermediate risk of 5 to 10%, or those who are at high risk of greater than 10%. And a few things that you should observe from this is, for one thing, the rates of bleeding, which are shown in these orange bars, increases along with the risk of vascular events. And I think that's something that we also see in other considerations, that whenever you're increasing your vascular risk, you're also increasing your bleeding risk. And what we see in these little red bars at the bottom is that the fatal events were all occurring in the patients who are at higher vascular risk, the fatal bleeding events, that is. And the other thing to observe is we see here in the aspirin versus placebo bars for the vascular events is that the reduction is roughly the same regardless of which risk group we choose. And if you take a look at serious vascular events avoided in the low risk, intermediate risk, and high risk population, they're kind of all over the map. In this particular analysis, we see that the greatest reduction was seen in patients in the intermediate risk. And in fact, the high risk population, greater than 10% 5-year risk or 20% 10-year risk, as we think of it here, was actually lower than in the low risk population. So risk stratification, once again, does not seem to be a reasonable strategy based on these data. Cancer was also a secondary outcome of the ASCEND trial in this diabetic population. And if you take a look at the rate ratios all the way down, regardless of what kind of cancer you are looking at, including gastrointestinal tract cancer, there does not seem to be any protective effect of long-term low-dose aspirin. So their conclusion was that aspirin use did indeed prevent serious vascular events, but also caused major bleeding events at roughly the same rate, that the absolute benefits were largely counterbalanced by the bleeding hazard, and that no effect was noted in cancer patients. Anytime you get a bunch of trials coming out like this at the same time, you're going to see the meta-analysis following very quickly thereafter. I've already inundated you with data, so all I'm going to say about these meta-analyses is that they followed very closely what we're seeing in the 3 trials. Wong demonstrated that intracranial bleeding, which was the primary outcome of this particular meta-analysis, increased by 37% in patients with aspirin. Mahmood showed that there was no reduction in the incidence of all-cause mortality, that there was an increase in major bleeding, and specifically an increase in intracranial hemorrhage. Zeng and colleagues, they observed that in their particular meta-analysis that there was a reduction in vascular events, and about an 11% reduction, and a similar increase in bleeding, with the numbers needed to treat and the numbers needed to harm pretty much in the same ballpark. So the Canadian Stroke Best Practices recommendations suggest that ASA is strongly recommended for secondary prevention in individuals with symptomatic cardiovascular, cerebrovascular, or peripheral arterial disease. And that is just so important to put into this statement, because when we're about to say that it shouldn't be used for primary events, we have to be so cautious to ensure that this very valuable tool that we use for secondary prevention of cardiovascular events is not lost. For primary prevention, the use of ASA is not recommended for primary prevention of a first vascular event, level A evidence. And this recommendation pertains to individuals with vascular risk factors who have not had a vascular event, and for healthy older individuals without vascular risk factors. The statement also goes on to say that the net benefit of ASA in individuals with asymptomatic atherosclerosis is uncertain. So what don't we know? Well, does the benefit of taking aspirin in patients with primary prevention outweigh the risk in patients with subclinical atherosclerosis? And by that I mean an individual with a high calcium score on a CT angiogram, or an individual with a small plaque noted in a carotid artery on a vascular ultrasound. We don't know the answer to that question. And the other question we don't know is, what about all those patients who've been taking it for years? Is it safe to just stop it? Or have there been some compensatory mechanisms that may put that individual at higher risk? We don't know the answer to that question yet. I'm not going to walk you through all of these recommendations. I will point out that all of these societies, American Diabetes Association, American College of Cardiology, American Heart Association, Thrombosis Canada, European Society of Cardiology, as well as the Canadian Cardiovascular Society, all have similar recommendations suggesting that ASA should not routinely be used. Some softer than others. The Americans still tend to be saying, well, maybe, but the Europeans and the Canadians, I think we are very clear that this is not an appropriate therapy. So with that, I will close, and I will thank you for your attention, and I'll open it to any questions if we have any.
Thank you very much, guys. So guys, we have some time now for questions for Dr. Bell.
This is actually a pretty easy topic. I could have given this talk by saying primary prevention using low-dose aspirin. Don't do it. Next speaker, please.
Right. You know, it's interesting because we've talked about this. I mean, the only question for primary care comes up with, with your diabetic, I could argue both ways, right? With ASCEND. So but you have bleeding risk and we have very little benefit. But if you had a diabetic that was found to have other things, I could maybe argue, maybe.
Well, it didn't really play up in the stratification analysis that strategy is useful. The other argument that may be made is if you're going to use aspirin in these patients, perhaps all the benefit is going to be seen in the first year or two that you use it. So I'm not really sure how to interpret that, frankly.
Yeah, I mean, I agree.
Do you automatically stop ASA used in primary prevention in patients who are tolerating it for years? Oh, so we have a question. Yeah, so my feeling is that, you know, I don't browbeat the patients that they have to stop taking this stuff. We don't really know that stopping aspirin is a completely safe strategy in such patients. My answer is I will ask the patient if they are taking aspirin. I haven't recommended aspirin for ages, so I don't have a lot of patients taking it. But ones who I determine are taking it, I ask them about taking it. I explain to them the risks and benefits. I make them understand that a baby aspirin is not quite as safe as you might think, and that it is associated with an increased risk of both gastrointestinal bleeding, bleeding anywhere else, as well as intracranial bleeding, what we fear the most. So, you know, I do have the discussion with them, and I generally speaking discourage them from continuing taking it, even without the evidence that discontinuation is safe. So I put that caveat in there, and I also mentioned that to the patients. Oh, I think we're done with questions. Thanks for your attention.
Thank you, Alan. Actually, we have one more coming up, actually.
Oh.
What about the management in hospitalized patients who have troponin rises with no associated ECG changes that get put on ASA?
So, you know, many of these patients, well, first of all, these patients need a complete workup to determine why they had a troponin rise. In many of these patients, it's going to be a type 2 MI or a supply-demand situation. We don't have great data at all in the use of antithrombotics broadly in patients with type 2 MI. Many of those patients, when you investigate them, have very limited coronary reserve and probably would warrant ASA on that basis, particularly in the presence of a troponin rise. But then, you know, this whole population, again, fits into that category of patients that they're kind of in between. They're not clearly secondary prevention. They're not clearly primary prevention. So, you know, how do we manage them? And sadly, despite the data that we just saw in tens of thousands of patients just from those 3 trials, add to that the tens of thousands that we saw in the antithrombotic trialists, we still don't have all the answers. I think we have a clear answer for patients who are clearly primary and for clearly secondary. For the ones in between, well, that's the art of medicine, isn't it?
Thanks, Alan. That was excellent. Thank you very much.